So, Dr. Cooper, we're coming up on just about 5 years since the beginning of the COVID pandemic. When did we know that COVID could have a profound impact on metabolism?
I think it was fairly quickly. We have a database at our clinic that has been developed in conjunction with the Diabesity Institute, the nonprofit that's helping sponsor our podcast here. What we started to see shortly after we were in that COVID period was that the numbers were looking like they weren't doing as well as our long-term numbers. So the patients were going backwards a little bit, which wasn't the case leading up to that year after year after year. So we started seeing that difference, and I think scientists across the country started seeing these things happening. And in fact, there was a lot of correlation pretty quickly with increasing risk of metabolic disease, whether it was from a cardiovascular standpoint or an obesity diabetes standpoint. Those linkages were being made fairly early.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see both of you.
Hello.
Hi.
On the show this week, the impact that COVID can have on your metabolic health. So, Dr. Cooper, we're coming up on 5 years since the beginning of the COVID pandemic. I can't believe it's been 5 years. In some ways, it feels like a lifetime. In other ways, it doesn't feel like 5 years. But I'm curious, there is now a proven correlation between COVID and metabolic health. I guess we should start with what the overarching idea is here. How many different ways COVID can impact your metabolism?
Well, all of the research that's been done, now that we do have multiple year data, it really is pointing to a significantly increased risk after COVID infections within that 3-year period afterwards. Increasing risk of diabetes, up to 40% greater risk of diabetes, for example, and markedly increased risk of progressing if someone already has diabetes, progressing in the severity, increased risk of obesity, increased risk of cardiovascular disease. So that would include incidence of heart attacks and strokes. And so there's significant connection to the metabolism, and it's not just for adults because there's been an increase in kids' onset of both type 1 and type 2 diabetes within a year of infection. And a lot of this was more pronounced or is more pronounced for people that are unvaccinated. So a lot of it is more severe for people who also were infected early on during the pandemic, because at that time, we really didn't have the vaccines and we didn't really know what was going on. And as time went on, we started to take some measures that were protecting us a little bit more, including the vaccines. But I think this data is still being collected, and so it's been really eye-opening to see those connections.
Well, you and I have a connection to a database at the Diabesity Foundation because we are on the board. And we have information for an incredible database. Do you want to talk more about that?
Yeah, I'm so grateful for this database. So unfortunately, a lot of times what happens for doctors is they get a lab report back and they're looking at it as though it's a snapshot. And they don't really have the capacity to see the trend lines over time for that patient or the collective group of patients and how that group is doing. So we realized early on that if metabolic dysfunction was going to be adequately addressed, then a database would be needed that not only collects all the data on each patient, but also within that practice that can analyze the outcomes of that entire practice in some key metabolic areas. And it also needs to be able to show that visually so that both patients and providers can quickly see those trends. And so we were so lucky because we had access to this database for years before the pandemic hit. And we were tracking all this data and we were tracking the outcomes. And that's why shortly after, within a year of the pandemic starting, we started noticing a backsliding of that progress that patients were making in these key areas. And many of our patients had gotten infected, many, because you remember it's really contagious. And so we were tracking the infections, we were tracking all of this data and noticed, wow, we've got to look more short term at what is that short term trend versus our previous longer term trends for these patients. So we were even seeing this clinically. And then it was reported throughout the country that these things were being noted.
Right, but through that database, you have years to compare and contrast.
We do. We have some people within the it's about there's about 2,500 people in the database, and I think a lot of them have 10 or more years of data in
Right. So it's pretty solid compare and contrast.
It is interesting to look at because we were already noticing that our outcomes were definitely much better than like national averages, way better in these key metabolic areas because we specialize in that and we're focusing on that as targets. But after the pandemic, those same patients that were making so much progress, they didn't slip all the way back to where they were, but there was just a slight pulling back of their progress. And I'd have to say that we're still battling it a little bit now. So that caused us to step up some of our approach in certain key areas that were more affected. And, it was hard to separate. Was it the stress? Because that is something to think about. With COVID hitting us, there was tremendous amount of stress brought on, and stress in all age groups, and isolation. There was a limitation. People weren't able to do the things that they normally were doing. So there was a lot of that we anticipated would affect people's health. But beyond that, there was some continuing impact on the metabolic system that we saw in a large number of our patients.
I think what's really interesting about that is that even in your patient population, who are a group of people who focus on being really aware of what's going on and aware of their metabolic system, and who visit the doctor regularly, and who get treatment, and who are paying attention to their bodies, it still affected them. The majority of Americans, let's face it, are not getting as good care as your population. So when you think about it, it's kind of interesting that your population still saw a rise in those problems when then you look at the general population, when it said that they were 40% more likely to develop diabetes, and there were just all these other problems that have happened after COVID that is really a big issue for the rest of the country.
Right. And our patients, we didn't have that degree of problem where people
Well,
who didn't
'cause they're
have
getting
diabetes
better.
that developed.
Honestly,
Right.
Dr. Cooper, they're getting better care.
Well, we were already targeting those outcomes as endpoints that we were
Right.
tracking. So if we were seeing a deflection where prediabetes was worsening, we were more aggressive about it for that
Exactly.
patient. But yes, I see what you're referring to, and it's true, and that is what. But the
Right.
fact that we could also see those little movements in our own patients that were already being under that type of metabolic care.
And we really should give a shout out to the Diabesity Institute. This is the nonprofit arm that you created to really further the mission. And that database is one thing that it allows. This podcast is because there are some generous donors who are contributing to the Institute. You both are on the board. So a huge shout out to the Diabesity Institute and the work that it's allowing. Dr. Cooper, what I'm interested in, you told us that the risk of cardiovascular disease is much higher among people, especially those infected early on in the pandemic. Tell us about that and why we think maybe that is the case.
I think that, there's still some research being done, of course, like trying to uncover that. But a couple of the factors are that they actually have found that the virus can actually attack plaque that's in the blood vessels and cause it to inflame. And so once that plaque, it could be soft plaque that's already pre-existing. So that's why people that with comorbidities, they were early on seeing that the outcomes were worse in people with comorbidities pre-existing. What that means is these are people who already had high cholesterol or high blood pressure or prediabetes, because the infection would come and attack those key areas that were making those conditions way worse. And so they have found that it was attacking that plaque, the soft plaque, and in doing so, triggering immune reactions that were causing a lot of inflammation of that plaque. And that enables the plaque to just become worse and worse and worse, and to eventually potentially rupture and migrate and cause a big heart attack or a stroke. But also there's damage to the blood vessel lining due to the inflammation too. And that's called the endothelium. And so that's associated with increasing blood pressure levels. And of course, I think most people are aware that there's clotting issues that have been attributed to COVID. Also, there can be an increase in problems with increased clotting, and blood clots also are associated with heart attacks and stroke risk going up. So I think all of those factors are playing a role. What they did notice, though, is people that were fully vaccinated had markedly lower risk, even if they had those pre-existing conditions. And that's why at first the vaccine efforts were appropriately being targeted toward people with pre-existing conditions and that were at more risk because we had limited vaccines. So the vaccines were trying to be distributed to that group initially that was at the highest risk of dying or having a serious post-COVID complication.
What's interesting is I've had COVID several times and I've been fully vaccinated the whole time, and I have a pre-existing condition with asthma, and every time it just settles down into my lungs and it lasts way longer than I would like it to last. But it's just so interesting how COVID is so specific to everyone's body. And my particular weakness in my body is my lungs. And it just goes there. And it just was this terrible, deep, deep rattling cough that lasted forever. And I tried Paxlovid. That's that sort of antiviral.
Right.
And it was so crazy, Dr. Cooper. I got right on it the first day of symptoms. And within 3 days, my symptoms were gone and I tested negative. And then 5 days later, it just came roaring back, and it was bad. And it just made me think, the whole reason I took the Paxlovid. But again, some people take Paxlovid, and it interferes with the virus's ability to replicate. But in my case, it was just, do they call that like a backlash or a rebound case?
I've heard of that with some other people who also had lung problems.
Yeah.
It's interesting. I have no idea if that means anything, but I have heard of that.
Yeah, there's a rebound that's noted for a lot of people with that, but there's also rebound with just COVID infections too, where people feel better and then all of a sudden it hits them again. So they've noted that too, that can happen just related to the infections too.
Let me ask you about, I did read that there was like protective advantages of those of us on the metabolic medicines like Ozempic and Mounjaro have, that because we were on these medicines that maybe it was a little bit protective.
Well, I know that they have seen that metformin.
And metformin,
Well, metformin has shown that it seems to be reducing. So if you're on metformin when you get the COVID infection, the risk of long COVID seems to be markedly reduced in people that were taking metformin at the time of infection.
Yeah.
So that was interesting too.
And refresh us on what exactly metformin is and what it does.
Metformin is a medicine. It's actually the most widely used medicine, I think, in the world for diabetes and prediabetes, insulin resistance, polycystic ovary syndrome. And it's been around for, I think now, probably 50 years now, 40, at least 40 years. So a lot of people have been on it. It helps to regulate the glucose response from the liver. And so in our fasting state, it keeps our blood sugar balanced and our insulin levels balanced in our fasting state primarily. And it's been found that people that were taking metformin at the time of their infection had much lower risk of having long-term sequelae from the COVID, from any kind of long-term complication, including long COVID. So it seemed to have quite a bit of protective effect. And then the people that were taking the GLP-1 at the time of infection had much lower risk of progressing from like pre-diabetes to diabetes or from diabetes to uncontrolled diabetes. So that definitely also,
I'm thinking maybe
helped.
those were my protective shields and the reason why I didn't get COVID this whole time. Plus, I have that little germinator, my germ protector that you insisted that I
You should do
get
that when you
for when I
travel.
was flying across the country all the time.
I don't think that metformin or GLP-1 have been shown to prevent you from getting infected with it.
No,
It's just more of how it would react in your body after. But yeah.
Wow.
I just consider myself very lucky, actually, because I was not always in the safest
Well, you may have
situations.
something that, they're looking at certain things that might put people at lower risk. Has to do with things like eosinophil counts. It's like an allergy cell level in our immune system that's thought to protect potentially against severe disease in some studies. And there's all kinds of little things they notice about people who don't get infected as often, but who really knows?
That's really interesting, though, that the fact that you had COVID can really increase your probability of getting type 1 and type 2 diabetes. Dr. Cooper, how should we examine that if we have had a bad case of COVID or 2 or 3 and we may be concerned that we're at risk of diabetes? What are some of the things that we should look out for?
Well, it's so interesting. If you've had COVID and you just don't feel 100%, like it's not something like you would experience with any other normal, have a virus and return back to 100%. If you're not feeling 100%, it's good to undergo some testing because it's not just the diabetes and the cardiovascular risk, but also people that have thyroid problems, such as like Hashimoto's, you may have heard of. Hashimoto's is the most common type of low thyroid condition. It's caused by an autoimmune problem where your body, and this is inherited genetically, where your body can make antibodies that attack your thyroid gland. Well, that condition is known to be sometimes exacerbated or flared up by exposure to certain viruses because it activates your immune system to make more of those antibodies to attack your thyroid more. So COVID is one of the infections, one of the viruses that could also cause a thyroid condition to become a lot worse. And in some cases, it can get really serious because it can raise those antibody levels so much that it goes beyond your thyroid of what you're experiencing throughout your body. And so I think anytime you're not feeling 100% after a COVID infection, then I think you should get checked out. Or if you had a really serious one that seemed pretty severe, even if you feel better, just getting checked out, and not just once, but maybe check to see, get your glucose levels measured, your cholesterol risk, maybe a heart scan if you're in that age group, just to make sure you're clear there so that you know more about your baseline health. And if you do have pre-existing thyroid condition, definitely getting that checked out. And I think just starting from that, and don't think, well, maybe this is just all in my head. Because if it is something that's progressing toward prediabetes or from prediabetes towards diabetes, it's going to just continue to do that. And you might get to a point where it's irreversible. So you want to catch it before it becomes severe.
Especially if you're feeling like tired or like you can't, like you need more naps. Don't just assume that's because like, oh, I'm getting older, I'm just tired, I'm just sleepy. I think that's what a lot of it started with one of my friends. She just felt really tired, and it ended up being like a whole like kidney thing, renal thing,
Hmm.
and they attributed it to long-term COVID.
I mean, they're thinking that the COVID infection can attack our organs and that that's the way that it may be promoting diabetes also is by attacking the pancreas and the
Yeah.
beta cells that produce insulin there. So it's definitely something to check out if you're not feeling, back to completely normal.
Yeah, this was a really dangerous, dangerous virus. It was not, it wasn't messing around.
Yeah.
And it's still here. That's the
Yeah,
thing.
and it's coming back. I mean, people sort of take it lightly. I'm starting to hear more and more about it on the news. I'm hearing more and more about it. It's like, don't think of it as just like, oh, it's just a little sniff. No, I'm a vaccine person. I believe in vaccines. I'm like, get the vaccine. Do not get this virus. It is not good.
Yeah, Dr. Cooper, is this an issue where we're going to have shots from now on when it comes to preventing COVID?
Well, so far it appears so. It definitely seems so because if you think about it, there seems to be a consistent pattern. If you actually look at the weekly death rates over the last few years, you can kind of start seeing that there are patterns, and also wastewater data is being collected as well that also shows. So there seems to be a pattern like we are entering a beginning of a surge because that occurs typically late fall, winter. The surge starts happening after a lull in the early fall. But there's also was a surge in the summer where we were in the US experiencing 1,300 deaths a week just this past 2024 summer in August. And so the low point in October was probably down to 300 to 500 a week. But that's still significant. And
That's a
so I
lot of
think
people.
I think people are kind of want to move past it for various reasons because of the stress that we associate with the whole experience. And we want to like just put it in our rear view mirror. But unfortunately, the virus isn't cooperating with that. So I still think during these surges, why not protect yourself? Why not wear a mask in public places if it's not uncomfortable? I mean, masks are not the worst thing in the world to wear if it protects you, or if you're flying and you're around people that you're not used to being around and there's not good ventilation. Why not wear a mask to protect yourself in surge times and be aware of when those surges are because it isn't really getting the press that we should be getting. So maybe check the wastewater data in your area and see what the numbers are looking like. It gives very nice graphs where it'll show if it's going down or it's going up. And that's pretty reliable. Whereas the reported positive levels are not reliable anymore because people just aren't reporting them.
That's interesting that you mentioned wastewater. That's one of the ways that polio is being tracked globally is they take samples from wastewater treatment plants, and it's much more reliable because it's instantaneous. It shows exactly who has polio and where the polio is. And it's interesting that they're tracking COVID that way because it's really a reliable tracker, isn't it?
It really is. We're really lucky here in Washington State because there are several wastewater data sites. So King County, where Seattle is located, there's a good data coming out of that. But some parts of the country, there's not any data from these wastewater sites. So if you happen to live in a zone where there is no data, maybe just tracking the state weekly death rates, it sounds morbid, but that could give you an idea of the incidence in your area.
Is this something that the health departments release, Dr. Cooper, in terms of the data?
The CDC
Okay.
does. And we can put something in the show notes maybe for the data tracker that the
Sure.
CDC has. And they keep revamping the website. And I'm sure for people who are listening that are in other countries, I'm sure that there are some similar tracking systems in the national health departments for various countries throughout the world.
Yeah, we should give a shout out to our friends in Great Britain, South Africa, Germany, Japan. We've got listeners all over the world, and it's so wonderful to have all of you gathering, and we'd love to hear from you. Dr. Cooper, what's the best way for people to get a question to you? Because I'd love to do another mailbag episode with our listeners.
I would send it to info at diabesityinstitute.org.
So as we start to wrap things up, this is just another example of how individual health is. Even, like you said, Dr. Cooper, among families and siblings. And it is just so unique how the human body responds to things like viruses and threats to food security and all that stuff. I'd love to know what the takeaway is from all this. Andrea, why don't we start with you?
I'd say be prepared for COVID. Just get your body ready to not get it. You don't want it. It's not fun. I mean, I've helped a lot of people who had it, and it is not. Look at this. Look at the data. I mean, this is not a good thing. The long term is even worse than we thought, I think. I mean, I don't think we knew what this was going to mean. We knew what the present of it was, and that wasn't good. And now we see the long term, and who knows what else they're going to find, which to me, I'm a rational person. And I look at it and I'm like, do everything you can not to get it.
I agree. And I think the thing that's encouraging for me, Dr. Cooper, is that for those of us who have metabolic syndrome, who are on drugs like metformin and Ozempic and drugs like that, we're finding that there's globally, generally positive health implications for those of us who are on those drugs. And I just find that really exciting. As we know more about that, I'll be watching closely because that has such an impact. But just as Andrea was saying, just not getting COVID would be a good thing. But now that we're looking at all the metabolic impacts and the threat of diabetes, the threat of heart disease, all of these exacerbating factors that are made worse by getting COVID, that's just one more reason to stay up on our vaccinations. And this fall is a great time to do it, not only for that, but for the flu vaccine as well. Dr. Cooper, what about you? What's your takeaway from this episode?
I think the main thing is that the COVID virus potentially can increase your risk for metabolic disease, obesity, type 2 diabetes, even type 1 in children, and cardiovascular disease, strokes, and heart attacks. And so those are all in that cardiometabolic wheelhouse. And so looking again, it just points us back to the metabolism and how important a healthy metabolism really is. And because who would think that a virus that comes along is going to have such a potential impact on our metabolism and these metabolic diseases? So once again, I think the importance of looking at the metabolism and having a healthy metabolism and protecting your metabolism is just reinforced by everything that we know about COVID.
And what I think, I'm going to take a big tangent right here. I love to listen to Star Talk, the podcast with Dr. Neil deGrasse Tyson. They did an episode on studying animals that hibernate and as it relates to space travel, because someday when we want to explore outside of our neighborhood, we're going to have to figure out how to shut down the metabolism of the astronauts who are traveling long distances for maybe months and even years. And they discovered some of these animals, both in warm climates and in cold climates, hibernate. There are some animals in Australia that hibernate after massive wildfires because there's no food, there's no vegetation. So they go into this state of hibernation, and it shuts down their entire metabolism to the point that it's about, they use maybe less than 1% of their daily calories that they normally would.
Wow.
So if I'm at 2,500 calories a day right now, that would be 2.5 calories that I could survive on in this state of metabolic sort of, shutdown. I guess what I'm trying to say in a long way is that we're just beginning to understand the complexities of metabolism. And I think the more study that we do, the more exciting it will become. And I think at some point, fixing broken metabolisms, for lack of a better phrase, will be, I think, really easy. That day isn't today, but thanks to the work of people like Dr. Emily Cooper and the Diabesity Institute, I think that day will come at some point. But I'd love your take on that, Dr. Cooper, when you hear about all the amazing things that organisms can do to regulate their metabolism.
I'm not surprised, because I think if you just look at just what happens to people when they just go on a diet, and that alerts the body that there's like low food supply, how much the metabolism can slow down for that, because it can swing like 1,000 calories pretty easily. So it doesn't surprise me. So I bet you're right. I wonder how that will work with humans, because as you do that shutdown, it triggers a lot of damaging things to happen too for human health. But I would love to hear that podcast. I'm going to go and listen to it and also look into that research because I'm curious about that.
Well, now that this podcast has been recorded for posterity, I'm guessing people 1,000 years from now will be chuckling at how primitive we are. It's like, like we're scratching things on the wall of the cave to transmit our knowledge. But this has been super fun. I always love spending time with the both of you. This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.